Alright guys, so this is going to be part 2 of our inhalational anesthetics lecture series. Let's go ahead and get started. So as always, we have a brief overview here of what we're going to cover in this lecture. We're also going to add MH there at the end. I know that was listed on the last lecture, but we're going to cover it here in this lecture. So getting started, let's talk a little bit more about nitrous oxide and some of the specifics about this gas that we commonly use in the OR. So nitrous oxide is much more soluble than nitrogen. So why is that important? We have nitrogen in a lot of the air containing spaces of our body. So nitrous is approximately 34 times more soluble than nitrogen. All right, so 34 times more soluble. That's an important figure for us to remember. So that means that for every 1 molecule of nitrogen that leaves a space, 34 molecules of nitrous oxide enter. All right. So if we thought about this, if you had a classroom with 18 students and 1 left, but then 34 entered, how quickly is this space going to get congested and fill up? Pretty quick, right? So this kind of leads to its clinical significance. All right, so in a compliant airspace, nitrous oxide increases the volume of the space, okay? So compliant, meaning that it responds to an increase in pressure. So as I apply more pressure and more volume, more gas into a space, it's going to get larger. Okay, so as the airspace becomes less compliant, it eventually converts to a fixed airspace. This is what we want to avoid in our lungs, right? When we convert the lungs from a compliant airspace to a fixed airspace, we end up with a pneumo. Okay. All right. In a fixed airspace, nitrous oxide is going to increase the pressure inside the space. So fixed airspace is like the middle ear that are non-compliant. It's just going to sit here and increase the volume, increase the volume, increase the volume. Well, we're non-compliant in our structure, so our pressure is going to increase. So, like we just covered, the rate of pressure change is going to depend on the compliance of the airspace, the partial pressure of nitrous oxide, or in other words, the concentration of nitrous oxide, the perfusion of the surrounding tissue, and time. Okay? So this becomes significant when we have these air-containing spaces in our bodies that primarily when surgeons perform procedures on them. So if we were doing a tympanoplasty, which is repair the eardrum, and the surgeon came in here and patched up this eardrum and made it all nice and pretty, and hopefully this patient's going to regain a lot of their hearing. If we were to give nitrous oxide to that patient, it's going to quickly raise that pressure in the middle ear. So if I raise this pressure here, you think this bone structure and all these sinuses that interact here are going to move? No. Pressure is going to push out on that brand new tympanic graft and damage it. All right. Also, the opposite can happen. So when we turn nitrous off and that partial pressure gradient changes, you also see it leave the space at that 34:1 ratio, and the space can actually shrink. And this attributes to the second gas effect, but it also, that rapid lower in pressure can lead to serious otitis or inflammation of that ear. All right. So another big one clinically that is talked about and that you will see in practice if you do retinal detachment repairs is nitrous oxide and its interaction with the ocular gas bubble. So when a retina detaches, you'll find that patients have to lay face down for an amount of time determined by the surgeon. But that's because this gas bubble is placed like a band-aid, okay, and it helps hold that repair in place and keep just the right amount of pressure on it. So if I was to start some nitrous to this patient, say they end up having to come in and have their gallbladder taken out, or they fractured their femur, whatever the case may be, that nitrous will find this gas bubble and expand this gas bubble, okay? All right, so we can obviously see why that would be a bad thing, right? All right, so most commonly, you're going to see sulfur hexafluoride is a common used bubble. And there's certain time limits that we have to abide by when these bubbles are used on when we can and can't use nitrous. Clinically, the cheat code to this situation is if I have a patient that comes in for whatever surgery, doesn't matter what, and they say I had retinal detachment surgery X amount of days ago, I'm not using nitrous at all. Okay, I'm not even going to turn it on. Not going to switch it over to my second gas. That way I don't even have to worry about it. But for boards, you guys need to remember some of these figures that we're about to talk about. So an SF6, which is the sulfur hexafluoride bubble, all right, we want to stop nitrous oxide at least 15 minutes before the bubble's placed to allow all that nitrous oxide to dissipate out of the body. And then after the bubble is placed, we're going to avoid nitrous for 7 to 10 days, okay? After just a regular air bubble, we're going to avoid nitrous oxide for 5 days. And then your perfluoropropane bubble is going to be your longest at 30 days, okay? Silicone oil bubbles, they're not actually bubbles, they're just oil. They have no contraindications. So we have air bubbles for 5 days, sulfur or SF6 bubbles for 7 to 10, and then your perfluoropropane bubble at 30 days, okay? Unfortunately, these are some figures that we need to remember. Just remember that air is the least, and then once you start getting into these funny types of bubbles, a general concept of this, if I was studying this and I wanted to remember it, I know that a regular air bubble is going to go away in 5 days, okay? So if I get it on Monday, it's gone by Friday. The sulfur hexafluoride is a little bit fancier, so it takes 7 to 10 days. It's a little bit over a week. It's going to stay around for a while. And then the perfluoropropane bubble is super, super nice. I'm going to keep it for a long, long time because I really like it. 30 days. I'm going to keep it for a whole month. All right. Basic breakdown. I'm trying to make this stuff simple so you can actually remember it. All right. So other things that nitrous does. It irreversibly inhibits vitamin B12 by blocking methionine synthase. Okay. So methionine synthase is an enzyme that's crucial for folate metabolism and myelin production. Well, we know that's important, and we know folate's important. Folic acid, we probably heard a lot of talk about that if you've ever had a baby or had somebody that you know has been pregnant. And myelin, that's that fancy stuff that, you know, surrounds our nerves and makes them work better. So when we inhibit methionine synthase, it leads to several side effects, okay? Reduced DNA synthesis, neuropathy, megaloblastic anemia, the patient becomes immunocompromised. Accumulation of homocysteine, which is an inflammatory marker, and it's linked to increased cardiovascular risk. Concerns about teratogenicity, and then also potential risk for spontaneous abortion, which makes sense if we think about folate and how important it is early in pregnancy, especially for those neurological structures to develop. All right, so what patients is this a high risk? So prolonged exposure with pre-existing B12 deficiency. So pre-existing B12 deficiency comes from mostly diet stuff. So alcoholism, strict vegan diets, or recreational use of nitrous oxide, and then pernicious anemia. All right, so we've heard Mac, Big Mac, all the Macs. So this is a common used term that discusses how much gas do we have on board. MAC changes. Okay, there's different definitions of different types of MAC. So it's important that we understand what these are. So MAC is an abbreviation for minimum alveolar concentration. It's the amount of inhalational anesthetic needed to block the nociceptive withdrawal reflex in 50% of the population. Okay? So 1 MAC is what that equals, okay? So the pain reflex in just 50% of the population, okay? So this is crucial when we think about MAC. This is not including any synergistic or additive effects of all of our other anesthetics that we use, okay? This is just discussing solely gas, all right? Because we all know that I can have a completely anesthetized patient without any gas on board, right? We can do that all with IV anesthetics. So just a very basic review here, so we don't forget. Isoflurane, MAC on 1.2, SIVO 2.0. You'll see a very wide varying range, but we're going to remember 2. It's usually 1.8 to 2.2 is your general range for SIVO. Desflurane 6.6 and nitrous oxide 104%. So MAC is a discussion of potency. It's a value of potency, all right? Because it relates to the percentage of gas that it takes to achieve 1 MAC. So 1.2% of isoflurane. So it's the most potent gas we use. Sevoflurane 2.0. So it's moderately potent, and so on. All right, so MAC is going to be additive, all right? Obviously, it's additive to all of our other anesthetics like we discussed. So what is MAC awake? MAC awake is the point where a patient begins to regain consciousness and open their eyes. All right, so during induction, if we're doing solely inhaled induction here, this typically is going to occur at 0.4 to 0.5 MAC. They could still regain consciousness and open their eyes. During recovery, it can drop as low as 0.15 MAC due to hysteresis. So, hysteresis is, we have the compartments in our body, right? All right, so say this is the brain. This is our bloodstream. And then this is our alveolar concentration, which correlates to our end tidal, correct? Our expired concentration. So if I have 1% left in my brain, and say 0.8% of that is coming out into my blood, and then I'm showing 0.5% in my alveolar concentration. This gradient is slowly changing, right? As I turn the gas off, it relays that back to the blood. The blood has all that dissolved anesthetic in it. It dissolves back in to the alveolar sacs, and then I breathe it out. And then that gradient's created between our different structures that we have used that gas on. It takes that gas and transfers it back into the blood, and then from the blood it goes back into the alveoli. So this is what hysteresis is. Because I have 0.15 expired, okay, this is our expired value, MAC on board, it doesn't mean that that's actually what's in the brain or in our target tissues. All right, MAC bar is going to refer to the concentration needed to block the body's autonomic response to intense pain, okay? It's around 1.5 MAC. To prevent any movement in 95% of patients, you need to hit approximately 1.3 MAC. Remember, okay, for all these values, this is just discussing inhaled anesthetics. We are not considering any other anesthetics that we have on board. All right, so I don't want you to go and think that you have to get every patient to 1.3 MAC to prevent movement. If you have narcotics, you have other adjuncts on board, that number decreases, right? We all know that. So preventing awareness and recall typically happens at lower concentrations around 0.4 to 0.5 MAC, okay? And then we discussed the MAC hour. It's defined as maintaining 1 MAC for a full hour, which is enough to stop movement, like we said, 50% of people. So this is also, say, a MAC hour could be, if I'm at a half MAC for 2 hours, okay, that's going to be 1 MAC hour. And this was a concern when we were discussing what gas? SIVO, because of compound A. All right, so a lot of things change our MAC values. All right, we're going to cover a lot of these. First, let's cover some drugs that increase MAC. Okay, drugs and conditions. So chronic alcohol consumption is going to increase MAC. Ephedrine, levodopa, MAOIs, and then acute illegal drug intoxication is also going to increase MAC. So the things that these have in common is these are hypermetabolic states, including the chronic alcohol consumption. We have enzyme induction, so we're able to metabolize our drugs quicker. Ephedrine, levodopa, all these things increase our sensory state. So we have to decrease the sensory state with anesthesia, so this makes it harder. Drugs that decrease MAC. Acute alcohol intoxication. These patients have already done most of the work for us. IV anesthetics, nitrous oxide, opioids, alpha-2 agonists like Precedex, hydroxyzine, lithium, and lidocaine. Okay. For electrolytes, there's really one main electrolyte that we need to remember. So hypernatremia is going to increase our MAC. Okay. Hyponatremia decreases MAC. We think about this, a hypernatremic state, it allows our nerves to depolarize quicker, which places them in a increased sensory level type of mode. So it's going to take a little more anesthetic to anesthetize these patients. When we think about age, this is extremely important. Okay, infants at 1 to 6 months old have the highest MAC values. Decreased MAC, premature babies, and then elderly age. After the age of 40, your MAC value decreases by 6% per decade. Okay, so think about that. If we had somebody that was 90, what would their MAC value be? All right, if we have 100%, okay, of our MAC. All right, and then say we're at 70% now, right? Because we have 6% per decade. That's going to be 5 decades. 6 times 5's what? 30. So 30% decrease. So we go from 100% MAC of SIVO to 70%. So what's 2.0? What's 70% of that? Just time to think about it. 1.4. All right. So 1.4% is that new MAC value for that patient. How does body temperature increase and decrease our MAC? Hyperthermia increases our MAC. Hypothermia decreases MAC. All right. So increased MAC is also triggered and related to our redheaded patients, okay? This is mostly due to genetic factors that affect pain sensitivity and anesthetic response. This genetic factor is the MC1R gene variant. That redheads commonly have mutations in this gene, which primarily is responsible for their hair color, but it also is involved in pain modulation and the response to anesthetics. They may increase pain sensitivity as well, which may require higher doses of anesthetic agents to achieve the same level of immobility or unconsciousness. Then altered receptor functioning makes it hard for these anesthetic pathways and standard concentrations of the anesthetic to work effectively. Okay. Also, things that decrease MAC that are kind of random. Hypotension, obviously, if we're not perfusing the brain, we're not metabolizing very much, we don't have much electrical activity. So to produce unconsciousness to somebody who's passed out, how do you do that? Well, if they passed out, they're not conscious, right? Hypoxia, same thing. Hypoxic tissue does not do metabolic activity very well, right? Anemia, cardiopulmonary bypass, metabolic acidosis, hypoosmolarity, postpartum 24 to 72 hours, and then a CO2 greater than 95. Okay, CO2, when you had patients, we talked about this in class, when you have patients that have COPD and they come in with a CO2 of 112, how awake are they? Not very awake most of the time, right? They're pretty somnolent. They're hypercarbic. In a hypercarbic state, CO2 will anesthetize your patient. Okay, so this is why it's important that we maintain normal CO2 levels. All right, so let's talk a little bit about how our volatile anesthetics actually work. So there's two major sites of action that we need to think about: brain and the spinal cord. So overall, volatile anesthetics are going to stimulate inhibitory receptors and inhibit stimulatory receptors. All right, one of the big ones that volatile anesthetics work on is your GABA A receptors. Okay, gamma aminobutyric acid, those A receptors. Volatile anesthetics are going to enhance the activity, okay, at the GABA A receptors. Okay, this increases the chloride influx into neurons, which hyperpolarizes the cell and reduces neural excitability, contributing to sedation and hypnosis. When we talk about the spine, there's a few more mechanisms that inhaled anesthetics work on. In red are some of the big ones, but overall, we're going to inhibit motor neurons. This is where we get our muscle relaxation and immobility. We're going to enhance glycine receptor activity, which is going to boost inhibition via glycine receptors, increasing neuron hyperpolarization. We're going to inhibit NMDA receptors, which are stimulatory receptors, which that's going to block excitatory pain transmission. Sodium channel inhibition is going to lead to inability of nerve tissue to depolarize and transmit information. We're going to suppress dorsal horn activity, so that's decreased pain signal transmission from the spinal cord to the brain. And we're going to inhibit polysynaptic reflexes, which suppress reflex pathways to prevent involuntary movement. We're reducing neurotransmitter release, blocking ascending pain pathways through the spinal thalamic tract, and we're modulating interneurons that affect the interneuron activity to ability to suppress reflexes and motor responses further. All right, so big ones are here, but it's important that you understand all of these as well. So overall, we stimulate these inhibitory pathways. We're stimulating them because we want to inhibit these signals as much as we can, right? We want to decrease our consciousness. And then we're going to inhibit stimulatory pathways, mainly these: nicotinic receptors, sodium channels, dendritic spine function and motility, and NMDA receptors, okay? All right, so each one of these reactions or clinical effects of inhaled anesthetics has an area in the brain or spinal cord that elicits this response. Right? It's important that we understand where these responses are controlled in our brain and spinal cord. Okay, so amnesia is going to come from the amygdala and the hippocampus. Okay, and the amygdala is responsible for emotion, responses to pain, and the formation of the stress response. Hippocampus is involved in memory function, and volatile anesthetics inhibit the activity in the hippocampus. Unconsciousness is elicited through cerebral cortex, the thalamus, and the reticular activating system. Okay. When we think about immobility, this is important. In the spinal cord, the ventral horn, which are your motor neurons, volatile anesthetics depress motor neuron activity, which is going to prevent reflexive movements and contribute to muscle relaxation and immobility. All right, it's important one right there. Analgesia. In the spinal thalamic tract, interception of nociceptive signals along the ascending pathway are inhibited. And then we have autonomic modulation, so preventing that sympathetic response in the pons and medulla. Volatile anesthetics inhibit the autonomic nervous system, particularly by decreasing the sympathetic nervous system activity. All right, so what do volatile anesthetics do to our heart and our cardiovascular system? Overall, blood pressure. We've all seen this, okay? Anesthetics lower MAP in a dose-dependent manner, and at equivalent doses, the difference between agents are minimal, okay? The primary cause of this is reduced intracellular calcium in vascular smooth muscle, which is going to lead to systemic vasodilation, decreasing the SVR and venous return. Secondary cause is reduced intracellular calcium in the cardiac myocytes, which is causes myocardial depression and decreased inotropy. All right, makes sense. We get cardiac instability and disorganized rhythms when we have alterations in our calcium levels. We get calcium chloride in code type situations. Calcium gluconate to somebody who maybe has a low potassium, or we want to stabilize that cardiac membrane, right? All right, a little bit of an opposite effect here. So when we're talking about nitrous oxide, the hemodynamic effects are primarily due to sympathetic nervous system activation. So when we combine with a volatile agent, nitrous oxide results in less blood pressure drop compared to using the MAC equivalent of a volatile agent alone. So you're going to see a slight sympathetic activation with nitrous oxide. Okay, so halogenated anesthetics are going to impact cardiac conduction in a dose-dependent fashion. So we're going to decrease SA node automaticity. We're going to slow the conduction through the AV node and the Purkinje system and ventricular pathways. This is going to lead to prolonged myocardial repolarization by reducing outward potassium currents, leading to a longer action potential and QT interval. All right. And then this is also going to alter our baroreceptor response, affecting our blood pressure regulation. Interestingly, when we provide desflurane and isoflurane, you can actually see an increase in heart rate due to the sympathetic nervous system activation from the respiratory irritation. These gases are extremely unfriendly to our lung tissue as far as the way that they irritate it. So you can actually see this with rapid increases in desflurane, and to a lesser extent your ISO. It's going to trigger a little bit of a tachycardia from that pulmonary irritation. All right. Usually this is managed through opioids, alpha-2 agonists, and beta blockers. So sometimes this response, like if we were to just only give desflurane and isoflurane, we would see this. But a lot of times we've already given the opioids. A lot of our patients are on beta-1 blockers. And sometimes we give some Precedex before we go back as well. So you may not see this 5 to 10% increase. As we discussed previously, nitrous is going to activate the SNS and increase the heart rate. What does our inhaled anesthetics do to our inotropy? So they're going to slightly reduce contractility, but the heart is going to still remain preload responsive. So most of our hypotension, like we said, is due to that vasculature relaxing and not having that preload there for our heart to pump. All right. Myocardial depression increases with higher doses. Okay, so if we give 8% sevoflurane, you're going to see severe myocardial depression. Nitrous oxide alone doesn't significantly affect contractility due to that sympathetic activation. But when we combine nitrous with opioids, it can cause myocardial depression. And we talked about this with my patients that I told you all that I gave opioids and we're on a little bit of nitrous. You can get some pretty severe bradycardia sometimes. All right, we talked about the SVR previously on that blood pressure slide, but volatiles are going to increase or cause intercellular calcium to decrease in our vasculature, which leads to systemic vasodilation and dropping of the SVR. SIVO has the lowest effect on this. All right. What do we do with coronary circulation? Well, this is kind of an interesting topic when you're discussing this theoretically. So volatile anesthetics reduce coronary vascular resistance by causing coronary vasodilation. This is especially significant in your small vessels, 20 to 50 micrometers. So this is going to increase coronary blood flow beyond the myocardial oxygen demand, right? Which ensures that we're getting sufficient blood flow to all of our heart. Potency of coronary vasodilation from greatest to least, ISO, DES, and then SIVO. So this is probably why you see isoflurane used pretty commonly in your open heart rooms. Isoflurane is the most potent coronary vasodilator, but doesn't contribute to coronary stills once thought. We'll talk about what coronary still is, and theoretically it's still taught in the textbooks, and it's something that you should be aware of. So volatile anesthetics actually precondition the myocardium and protect it from ischemia, because we're increasing the amount of coronary blood flow beyond that O2 demand. So we're hyperoxygenating all this tissue, and we're allowing it to receive more blood flow than what it needs. So coronary still, we mentioned it, is when blood is diverted from diseased vessels to healthy ones. But this is rarely going to happen in practice with volatile agents, okay? So this is more of a theoretical basis. So the coronary still phenomenon, when we have a healthy vessel, all right, when we dilate it, it's able to expand in size, okay, because it's healthy. When we have an atherosclerotic vessel that's got all these calcifications and everything, it's fixed, okay? I want you to think about it like that. So it's not able to expand due to demand. So what happens is, when we give these volatiles, the healthy vessels theoretically dilate, and this one doesn't. All right, when we can flow and walk through this hallway easier, this is the easiest path. It's the path of least resistance versus this atherosclerotic vessel. It's a lot harder to go through. Okay, so this is going to reduce the blood flow in those ischemic areas. The heart itself can't increase its O2 extraction much past 75%. So to meet increased demand, we boost our coronary blood flow. So when we have increased demand in this situation, those stenotic vessels are already maxed out. Okay, they can't compensate during increased O2 demand, which might trigger coronary still. Usually, when you start to see ST elevation or depression, and you see ischemic changes in your patients, it's primarily due to some other hypotension or sympathetic stress. It's not due to coronary still. It's not due to our inhaled anesthetics causing this to happen. Now, these diseased vessels, like we said, they don't dilate. So if we have increased oxygen demand, then this vessel's fixed. It's only getting X amount of blood flow. So the things that we can do to increase blood flow are going to be based on the amount of FiO2 that we can deliver through this blood flow, or PaO2. All right. So volatile anesthetics are actually going to improve myocardial oxygen supply demand balance by reducing myocardial work. They lower contractility and heart rate, like we previously discussed. Isoflurane, desflurane, and SIVO lower coronary vascular resistance but preserve coronary artery regulation, ensuring blood flow adapts to myocardial needs. All right. When we use volatile anesthetics with nitrous, the SNS activation can limit this vasodilation and may affect coronary blood flow to a greater extent. But overall, in patients with coronary artery disease, volatile anesthetics are beneficial as they reduce myocardial oxygen consumption while maintaining coronary perfusion. All right. Volatile anesthetics are going to be preferred in cardiac surgery because of this. Here's your little graph or table that lists out your different effects, okay? There's a summary of each one of these. I would notice the differences amongst each one, okay? All right, so what about our lungs? So volatile anesthetics cause a dose-dependent suppression of the central chemoreceptor and respiratory muscles, leading to hypercarbia. All right, so there's that dose-dependent suppression, okay? This changes the respiratory pattern, reduces our response to CO2, and decreases motor neuron output and muscle tone in the upper airway and thoracic muscles. So volatile anesthetics alter that respiratory pattern, meaning they decrease tidal volume and increase respiratory rate. All right. Even though that increased respiratory rate's there, it does not compensate enough to prevent an increase in our CO2. Okay, smaller, quicker breaths increase the dead space to tidal volume ratio, contributing to hypercarbia as well. So like we said earlier, volatile anesthetics depress the CO2 response. Okay, so this shifts the CO2 response curve down and to the right. All right, this is going to increase our apnea threshold. So patients require a higher level of CO2 to breathe. All right, so this can lead to hypercarbia, and unfortunately, hypercarbia also causes respiratory depression. So this is why our emergence is such a delicate time during our anesthetic measurement. All right, then we talk about airway irritation. So when we use inhaled anesthetics for mask inductions, mask inhalation induction, sevoflurane is preferred because it has the least amount of airway irritation, all right, especially in peds. It's going to have a rapid onset and smooth emergence. All right. DES has that fast onset, but it's highly irritating to airways. Same with the ISO, moderate irritation, and it's mainly used just for maintenance, okay? So, what factors influence airway irritation? Like we said, higher concentrations and rapid increases lead to more irritation. The desflurane and isoflurane causing that increase in heart rate is primarily due to the airway irritation. Also, patient factors, okay? We have pediatric patients, their airways are a little more fragile. Asthmatics and smokers are also more prone to irritation. We can humidify gases, which reduces irritation from cold, dry gases. So clinically, when we think about pediatric inductions, we're going to use SEVO because of that minimal irritation. Also with adult induction, we do the same thing for our patients with asthma and COPD. And then postoperatively, desflurane and isoflurane are more likely to cause coughing or laryngospasm at emergence. So that's important to remember. What does our volatiles do to our upper airway? So that smooth muscle relaxation is going to lead to relaxation of the genoglossus and the tensor palatine muscles. Right? This is going to cause upper airway obstruction. Okay? And also the pulmonary muscle relaxation leads to our decreased FRC and decreased overall ventilation, which we talked about, those low tidal volume breaths, right? When we talk about these reactive airways in like asthmatics and patients like that, sevoflurane is going to cause minimal airway resistance, meaning that it's ideal for patients with reactive airways. It promotes bronchodilation and reducing resistance during spontaneous breathing. Okay. Desflurane increases airway resistance due to its pungency and irritant properties, leading to coughing, laryngospasm, and bronchospasm, particularly when used at high concentrations or for rapid induction. ISO also causes the same things, but mild to moderate increases in airway resistance due to its irritating nature. Interestingly, though, ISO has some bronchodilatory effects at lower concentrations. Overall, all volatile anesthetics, particularly sevoflurane and isoflurane, possess bronchodilatory properties which can decrease airway resistance in patients with bronchoconstriction. So this is why if we have an intraoperative bronchospasm, I'm going to turn my gas up and increase that concentration to hopefully help bronchodilate those bronchioles that are trying to spasm on me. Okay. So we discussed how volatile anesthetics change our CO2 response, but what about our oxygen response? So peripheral chemoreceptors in our carotid bodies monitor for hypoxemia. All right, they usually trigger a response with our PaO2 of 60, which is equivalent to an O2 saturation of 90%, by increasing ventilation to restore that oxygenation. Okay, and this is done through afferent pathways of our chemoreceptors. So those carotid bodies relay the signals to the respiratory center via the glossopharyngeal nerve or cranial nerve 9. And the aortic bodies send afferent signals through the vagus nerve, but the aortic bodies are more sensitive to like blood pressure changes. So talking about our carotid bodies here. So volatile anesthetics are going to impair peripheral chemoreceptors for several hours post-anesthesia, reducing hypoxic ventilatory drive, okay? At 0.1 Mach, the response to acute hypoxia is impaired, but the response to CO2 remains intact. This is due to our glomus type 1 cells in the carotid bodies that provide that sensory arm of the hypoxic drive. So the theory is that when we metabolize these volatile anesthetics, is that they create reactive oxygen species, or ROS, which are going to impair the function of these cells. Okay, so the level of hypoxic drive inhibition is linked to the degree of anesthetic metabolism. Oh, so hepatic metabolism. Sevoflurane being the most, iso is in the middle, with desflurane coming in last there. So that's important to remember. So nitrous also impairs carotid body responses, but it's via a different mechanism than our volatiles. So this physiology is going to be critical in patients who depend on hypoxic drive, okay? Like our patients with sleep apnea or emphysema. Desflurane is going to be the preferred agent to prevent this decrease in hypoxic drive. So this is an important one. Unlike their effect on CO2, okay, on the CO2 ventilatory response, pain and surgical stimuli do not reverse the depression on a hypoxic ventilatory drive. So if we have a patient that's hypercarbic with a CO2 of 60 and we're trying to wake them up, and we perform a jaw thrush, which is generally elicits a painful response, we can override that hypercarbia. We can override that decrease in the CO2 response curve with that painful stimuli. With these patients, they can be wide awake with emphysema, and no painful stimuli is going to make them oxygenate better. No painful stimuli is going to make them breathe more from that hypoxia. Okay. So what do volatiles do to our brain? Well, if we think about it, cerebral metabolic rate is going to be overall reduced. Okay, so it's going to be based on the depression of electrical activity in the brain. But once the brain is isoelectric, volatiles can't decrease the metabolic rate any farther. Okay, so the brain's not producing any electrical activity, but the brain is still metabolizing and producing energy to provide homeostasis. Okay, those cells are just existing and being homeostatic in this environment. They're not creating thoughts, but they're just surviving. Sevoflurane at high concentrations can produce seizure activity. Okay, it's most commonly going to be seen in your patients, like your peds patients, where you're dialing up to 8% and you're getting those high concentrations very quickly. So cerebral vascular effects. So the brain balances cerebral vasodilation with cerebral metabolism. At concentrations above a half Mach, volatile agents increase cerebral blood flow. Okay, this is going to increase the overall blood flow with a decreased metabolic rate. So if we increase the cerebral blood flow through vasodilation and inhibition of that autoregulation, this is going to increase what? Our ICP. So this is all good and well, except for our patients that have that pre-existing increased ICP. All right. So CSF volume, there's minimal effect, but we do need to know that isoflurane is the only volatile that is absorbed in the CSF. Desflurane increases the CSF production, and sevoflurane decreases CSF production. So for everybody that's done a spine case, you have had a neuromonitoring tech that's monitored evoked potentials. So evoked potentials are going to be used to monitor the integrity of the neural pathways during surgery. There's four main types. There's somatosensory or SSEPs, motors, which are MEPs, MEPs, visual, so visual evoked potential, and brain auditory, BAEPs. So the SSEPs are produced by applying current to peripheral nerves, like the ulnar or tibial nerve, and monitoring the signal as it travels to the contralateral cerebral cortex. Motor evoked potentials monitor the integrity of the corticospinal tract, and the anterior spinal artery is what's going to perfuse this region of the spinal cord. It's important to know what arteries perfuse these areas. Why? Well, if we nick one of those during surgery and the neuromonitoring tech says, I've lost all of my motors on X side, well, we know that most likely we have hit the anterior spinal artery. All right. For SSEPs, they monitor the integrity of the dorsal column, which is the medial and meniscus column. All right. The posterior spinal arteries perfuse this region. All right. So when we talk about somatosensory and our motor evoked potentials, they're not going to be interchangeable. Okay. SSEPs monitor the dorsal cord, while MEPs monitor the anterior cord. So what's important to know about gases is it's also a dose-dependent suppression of these evoked potentials. So higher doses reduce amplitude and increase latency of evoked potentials. So when we reduce amplitude, that means that before we started giving volatiles, our amplitude was here. And now that we've started and we turn volatiles on, our amplitude is here. Latency, all right, if this is an x-axis with time, say seconds, on the x-axis here, well, we elicit a signal and we don't get a response. So here's our response before volatile anesthetics. Here's our response after volatile anesthetics. So it's increased the time that it takes for that signal to travel, that evoked potential to travel from wherever it's being stimulated to the receiving end. Okay. So SSEPs are going to have reduced amplitude with volatile anesthetics at above a half Mach. Okay. Motor evoked potentials are going to be highly sensitive as well. All right. So they're going to be suppressed even at 0.3 Mach. This is why when we think about these cases with monitoring, neuromonitoring, we prefer a TIVA, because then they're able to monitor all of these evoked potentials at the highest degree of measurement. All right, our brain auditory evoked potentials are least effective and are considered reliable even with volatiles. So goals are to limit Mach. We want to keep volatile anesthetics at a half Mach or lower. Okay. We want to use IV agents to supplement our volatile agents if we have to use them, or solely use these IV agents. All right. And obviously TIVA is going to be best, okay? It is definitely the standard that we want to use. So a quick little slide, an overview about malignant hyperthermia. So all volatile anesthetics may trigger malignant hyperthermia except nitrous, right? It's a gas. Malignant hyperthermia is rare, okay? But it is genetically passed on. So signs of MH, tachycardia, hypertension, hyperkalemia, muscle rigidity, hyperthermia. But the first sign is going to be a drastic increase in your CO2 that is non-responsive to changes in your minute ventilation. So we see our CO2s creeping up, and we increase our respiratory rate, we increase our tidal volume, but the CO2 keeps on trucking. It doesn't care. This is a sign of MH. This muscle rigidity on induction can be a sign of MH. All right, succinylcholine can also cause malignant hyperthermia. So this is something to watch out for. All right, that patients, their jaw gets very rigid, body becomes rigid. That's a sign that you could be having an early recognition of MH reaction. All right, this is all due to an inappropriate release of calcium. All right, our RYR1 receptors release this calcium and don't take it back up. Okay, we're going to treat this with dantrolene or Ryanodex. We're going to lower that elevated temperature, and we're going to restore the electrolyte imbalances that happen with MH. Okay, and we'll talk more about this later on.